The following podcast is part of a certified educational activity titled The Type 2 Inflammation Connection in CRS with NP, Optimizing Patient Identification and Targeted Treatments. Access the entire activity and complete the post-test at peerview.com/MNA860. Downloadable slides and practice aids are also available.
Hello, and welcome to the Type 2 Inflammation Connection in CRS with Nasal Polyps, Optimizing Patient Identification and Targeted Treatments. This is the first part of our two-part series, Filling the Gaps in T2 Inflammation-Driven CRS with Nasal Polyps, Unmet Needs and Identifying Patients for Biologic Treatment. I'm Flavia Hoyt from National Jewish Health, and joining me today is Christine Franzese from the University of Missouri.
Thank you. It's so good to be here.
Goals for today. During the presentation, we're going to learn a couple things. One will be that individual characteristics of disease and clinical considerations can be used to determine which patients with CRS with nasal polyps are candidates for treatment with biologic therapy. And then importantly, we're going to look at incorporating biologic therapy into the treatment of patients with CRS with nasal polyps and talk about how this should be guided by the latest evidence, inflammatory endotypes, and presence of type 2 inflammatory comorbidities. So first, we'll talk about the unmet needs in CRS with nasal polyps and the role of biologics in hopefully filling these needs. So what is chronic rhinosinusitis? It is an inflammatory condition with multiple phenotypes. So there is a time point here. It has to be greater than 12 weeks duration of greater than or equal to 2 symptoms. So the symptoms include drainage, either rhinorrhea, postnasal drip, or both, nasal congestion or obstruction, facial pain, pressure, fullness, and decreased sense of smell. And again, you need 2 or more. Most of our patients end up having all of them in some capacity or another. And then in addition to the symptoms, you also need objective criteria of inflammation. So greater than or equal to 1, either by endoscopy, documenting drainage, mucosal edema, or polyps, or a sinus CT scan that shows inflammation of the paranasal sinuses. And in terms of chronic rhinosinusitis, we know it's actually quite common. Approximately 14% of adults in the United States would meet these symptom criteria for CRS. The typical age of diagnosis is in adulthood, so 40 to 60 years. And it's more common in men, about 62%. But certain studies actually suggest that women have more severe disease. So that's an interesting thing to keep in mind in clinic. And we know that CRS with nasal polyps really has a huge impact on quality of life. There's the Health Utility Index that shows that the index for CRS with nasal polyps is similar to that of asthma, of coronary artery disease needing a stent, end-stage renal disease on hemodialysis. So really significant conditions that impact quality of life, and CRS with nasal polyps falls right up there. And in terms of what causes the impact on quality of life, we think about both the physical and emotional domains. So nasal symptoms, again, the same ones we just spoke about, as well as cough, aggravation of asthma, and then ear symptoms. A lot of our patients really complain about this ear congestion and pain or pressure that is quite bothersome and pretty persistent. And all of this to say that then they develop anxiety, depression, feeling like you have a cold kind of 24/7 is never a good feeling, and often impacts sleep. So now, sleep is impacted. You end up with daytime fatigue as a result, and it's kind of this vicious cycle. So real impact on quality of life. And then thinking about the inflammatory endotype, so we talk about phenotypes and endotypes. A phenotype of CRS would be whether or not a patient has nasal polyps. Endotypes digs a little deeper and thinks about the inflammatory milieu that you're dealing with in a certain patient. And if you look at this graph here, just thinking about all CRS on the left, CRS without nasal polyps in the middle, and then CRS with nasal polyps, the first thing that stands out is in red, the type 2 inflammation. So we know that type 2 inflammation is very prominent in CRS, whether or not there are nasal polyps. But particularly in the case of the patients with nasal polyps, you see a large part of that pie chart is red. And then I think what's actually even more interesting is all the other different colors. So it's not just type 2 inflammation. You see plenty of type 1, type 3, and a lot of mixed inflammation. So thinking about your patient as just a type 2 inflammatory patient will be doing them a disservice, because there might be some more to that story, especially if they're not responding to kind of the typical therapies that we use to start. And here's a little deeper dive into the pathophysiology of CRS with nasal polyps. I'm an allergist immunologist, so I could talk about these diagrams all day, but I won't belabor the point. um, the most important thing, I think, is to start at the epithelium. So at the top of this slide, you see the airway epithelium of the upper airway, and you can see that all sorts of triggers impact that epithelium. So viruses, proteases, particulates, pollutants, allergens, bacteria, fungi, etc. Once they hit the airway epithelium, they can cause epithelial disruption. And then, importantly, that trigger of inflammation, which starts with the epithelial alarmins. So, the alarmins that are shown here are the most pivotal ones that we know about, especially as type 2 inflammation inducers: IL 25, IL 33, and TSLP. And so once they get released, then all the downstream inflammation starts getting activated. And it happens through antigen independent, so more the innate immune system with the help of that ILC2 cell that you see in the center of the slide. And that kind of starts the downstream inflammation. And then there's also some antigen dependent inflammation that is happening through the T cell. And then you see all the different cells that are involved. So we have more than just the T cell, the B cell, the eosinophil. We've heard a lot about, with IL-5 being the main cytokine that's driving that, the mast cell, which is very relevant when we're talking about allergic inflammation, but also macrophages, goblet cells, given that this is a disease with a lot of mucus production, and basophils as well. So a very kind of rich inflammatory milieu, and there's a lot of crosstalk kind of up and down in this pathway. But again, it starts at the epithelium. In terms of type 2 inflammatory comorbidities, this is a very important thing to think about in our patients because the upper and lower airway talk. And so many patients with upper airway disease have lower airway comorbidities and vice versa. And so we have to think about the patient as a whole and really talk about the whole airway. So with that in mind, up to 65% of patients with chronic rhinosinusitis and nasal polyps have comorbid asthma. And the prevalence of asthma in the general population is only 8.5%. So you can really get a sense that in these patients, there's a much higher risk for asthma. Really important just to ask, are you ever short of breath? Are you coughing? Are you wheezing? If you don't ask, they may not mention it because, again, the CRS alone has such an impact on quality of life that will probably be their focus of the clinic visit. But ask about asthma. Many times, we talked about CRS with nasal polyps manifesting in that middle age, right, between age 40 and 60. So oftentimes it can be associated with adult onset asthma. So this is a patient who doesn't come in with a diagnosis of asthma that they've had for years. More reason to bring it up and ask about it in clinic. We also know that patients who have both CRS with nasal polyps and asthma have more severe type 2 inflammation, and this affects both the upper airway and the lower airway. So these patients tend to do worse with regards to, surgical outcomes with regards to their asthma control. And up to 26% of the patients who have CRS with nasal polyps and comorbid asthma are the patients who have AERD, so aspirin exacerbated respiratory disease or nonsteroidal anti-inflammatory drug exacerbated respiratory disease. Lots of different names for the same syndrome. And the idea there is you have the chronic rhinosinusitis with nasal polyps, you've got the asthma, a lot of eosinophilic inflammation, and then the aspirin sensitivity. And these patients tend to be the most severe, particularly with regard to their CRS outcomes. And then, with that in mind, the impact on quality of life is going to be worse, again, in patients who have both the upper and the lower airway involved. So, kind of looking at this graph here on the left, you can see the population norm in terms of quality of life in blue, and then in orange is going to be your CRS with nasal polyp. And there is a significant difference both in terms of the physical component as well as the mental component for those patients with CRS have worse quality of life. And then breaking it down a little further on the right, in orange are going to be the CRS with nasal polyp patients who do not have asthma. In green are those patients with asthma. And then in purple, again, that more severe category who has not just asthma, but the aspirin exacerbated respiratory disease. And you can see that there's a significant difference in all of the categories that are being compared, and it's getting worse as you go along. So the asthma makes it worse, the ARD or NERD makes it even worse in terms of both the physical component and the mental component. And along with that, the patients who are not doing well are the patients who are getting oral steroid bursts and sometimes even chronic oral steroids. And more recently, we've actually been focusing on those side effects of those steroids and just how little steroids are needed in order to kind of start triggering those side effects. And so as a community, I think we're more aware of these side effects, and it's really our responsibility to teach our patients, make sure that they're aware of those side effects, because again, if you're feeling miserable from this disease and you get a steroid and that's allowing you to breathe and smell and sleep, it's hard not to want that steroid more and more. And so really it's our job to kind of try to minimize the oral steroids, and then also educate our patients. So in terms of numbers, 64.7% and 41% of patients used either all cause or CRS with nasal polyp related oral or systemic corticosteroids, respectively. 36% had greater than or equal to one oral corticosteroid bursts, which is the equivalent of greater than or equal to 20 milligrams for 3 to 28 days. So, again, these doses stack up, even though it just feels like one burst. If it's a long enough burst and the dose is high enough, you're going to start stacking up those side effects. The use is higher in patients with asthma or those with who have previously had a surgery, because again, those are your more severe patients. And 23.5% had a cumulative annual dose of greater than or equal to 400 milligrams. So again, you can just imagine how much steroid that is. We know that the side effects that come with steroids include, affecting the heart, the brain, the bones, the eyes, pretty much everything head to toe. And so just counseling patients, and knowing that we have increased healthcare costs in terms of those patients who are getting steroids, and then of course increased downstream effects. A couple other studies here. So, at least 40% of CRS with nasal polyp cases may be uncontrolled despite receiving maximal pharmacotherapy and endoscopic sinus surgery. So, just again, referring back to unmet needs, we've got a lot of great tools, but 40% of patients still remain uncontrolled. And then a 12-year follow-up study after endoscopic sinus surgery showed that 79% of patients developed recurrent nasal polyps over 12 years, and 37% required a revision surgery. And again, the patients with asthma, and especially those patients with ARD, are the ones who are kind of stacking these surgeries up even faster. So, can biologics help to fill the treatment gap? I will tell you, yes, it can. And we're very excited about them because they've been, I think, life changing for our patients. But the idea here is that we are going back to that complicated pathophysiology slide, and we're looking at what is driving the inflammation, and we're targeting that more specifically, so that we don't get all the way down to the downstream inflammation and mucus and all of that, where patients are miserable and needing the oral steroids. So blocking upstream epithelial alarmins. And Dr. Franzese is going to talk a little bit more about the specific therapies, but and then type 2 inflammatory pathways, so IL-4/13, IL-5, and IgE. All of these different molecules now have approved agents, and our hope is that by blocking those specific cytokines, we can lead to more sustained effect. Durable improvements, so reducing nasal polyp size, congestion, sinus opacification, all the things that really matter to improve quality of life and sense of smell. And we've seen impacts on all of these from the various biologics that are available. We talked about the risks of systemic corticosteroids and how important it is to avoid them, and also revision surgeries. So, needing surgery after surgery after surgery, if we can avoid that at all, we would love to do that. So, biologics definitely fill that gap. And then because we talked about comorbidities, these patients who are being treated for their upper airway inflammation can also be treated for their lower inflammation in many cases with the same agent. And so you can improve asthma control and health related quality of life in both the upper and lower airway, which is even more fantastic. So, Dr. Francis, let me ask you, in clinic, I mean, I just talked about a lot of different things. What is the most important thing that you think, in talking with patients, kind of emphasizing either discovering unmet needs from them or emphasizing kind of how to fill in those gaps?
So I think, and you done a fantastic job of summarizing like such a huge amount of information. Talking with patients is, I think, getting to what their goals are for treatment. Whether we're thinking about surgery, whether we're thinking about different monoclonal antibody therapies, kind of what are their desires, what are their expectations, um, and then how can we help with them choose the best options for them.
Yep. No, I agree. And I think we'll talk a little bit more about shared decision making, but that's where it is, right?
I will take over with the first step in improving our nasal polyp care journey with our patients by trying to identify candidates for biologic therapy. So let's talk about our traditional approaches. Of course, nasal saline irrigations, they're the hallmark of these, the mainstay of treatment. Even if you haven't had sinus surgery, they can be highly beneficial, but there are the workhorse. In addition to intranasal steroids, topical nasal steroid sprays, or putting corticosteroids in rinses, these can be very helpful. This is really the long-term treatment option that we discuss with patients. And there are several different delivery methods. It can be nasal sprays, it can be the exhalation delivery system. There are different steroid-eluting stents that can be used, some in the office, some that are used in the operating room. And then off-label, there are different drops and irrigation methods that you can talk about with your patients. Antibiotics, whether they are topical or oral, are useful potentially in treating exacerbations, but they don't really have a long-term place in most of our endotypes. Leukotriene modifiers can be somewhat helpful, particularly in our AERD patients that may be undergoing aspirin desensitization therapy. And then systemic steroids, as Dr. Hoyt sort of touched on, how we understand the long-term consequences of these. We really try to limit the bursts, not just the length of these bursts, of the dosage, but also how frequently we're giving them because of the adverse events that can be associated with them, the lifetime cumulative adverse events. So when medical treatment is unsuccessful, this is when we talk about surgery and potentially what the goals are for surgery. Patients may have different desires. Most frequently, if people are considering surgery, they want to be able to breathe through their nose right away. That's one of the biggest desires we'll hear. Also, can I smell again? Breathing through my nose without any kind of drainage, removing polyps, decreasing the inflammatory load. All of these are patient goals. We also want to open up the sinuses, remove inflammatory tissue, and enlarge the sinus opening so that we can deliver those topical therapies better to those involved sinuses. And then, certainly after surgery, our goal is to maintain these with these different types of therapies as well as we can, because the goal for all of our patients is really one and done. Ideally, we do one surgery and we don't have to do it again. However, polyps sometimes can be the gift that keeps on giving. There have been a number of studies that have looked at this over the years. The Daconda study from 2017 is one of the most popular cited ones. This was where we hear that like 40% recurrence potentially in 6 months and then at 18 months. Um, One of the caveats to this is in that study, the polyp size wasn't necessarily rated other than a polyp had come back. It could be a small polyp, could be a very large polyp, but essentially it was just noted whether there was a polyp or polypoid mucosa. But still, polyps do tend to come back in some of the newer endoscopic approaches because we're all aware that sinus surgery has really evolved not just in the last few decades but even in the last decade. The treatment approaches, the targeted approaches, the what we can do endoscopically has really markedly advanced. And so with these new different approaches really targeting where polyps are coming from, a 2-year polyp recurrence can be as low as 10% or less. And but we do know that sending tissue from surgery can be helpful because if you have a lot of markers of type 2 inflammation in that tissue, that usually is indicative of more severe sinus disease and does elevate your risk of potential recurrence. So here we have that beautiful diagram that talked about the different cytokines and cells that are involved in this inflammatory cascade. And you'll see now there are some red additions. These are pointing out the different areas where we have monoclonal antibodies that potentially can block either these different antibodies, these cytokines, or act directly on cell receptors. So we have tezepelumab, which got newly approved, which is a anti-TSLP blocker. We have omalizumab, which is an anti-human IgE monoclonal antibody. We have two different antibodies that will target IL-4 and IL-13, dupilumab and stepokibart. Now you'll notice stepokibart, the BART is new since 2022. The naming conventions have changed, so we'll have to get a little used to that. We're not going to see MABs anymore, at least from the newer ones. And then we have mepolizumab as well as depemokimab. Those are an IL-5 cytokine blocker, and benralizumab actually binds to the IL-5 receptor itself. So it's really exciting. We have a number of different therapies that can target this inflammatory cascade. So here are the currently approved biologic therapies: dupilumab, omalizumab, mepolizumab, and tezepelumab. You'll note that dupilumab and tezepelumab are for 12 years old and up, whereas the other two are for 18 and up, so adults only. And you'll notice a number of them are actually indicated for other type 2 inflammatory conditions. So, when we look at the severity of disease, how can we assess this? What are good ways potentially to measure it? Well, some objective measurements include nasal polyp scoring. So there's no one specific scoring system that is universally used or advocated for. There have been other ones used in FDA approved studies for nasal polyps. The most common ones feature a 0 to 4 scoring system where you grade each side and then add them together for a total maximum of 8. But there can be other ones that use numbers and letters. There's also not an MCID for the scoring system. So, what is clinically meaningful may vary depending on what system you're using. The SNOT 22 score is a quality of life validated measure that goes from 0 to 110. That does have an MCID of 8.9. But generally, anything over 50 is considered to be severe disease. And that's usually what we'll see enrolled in our nasal polyp trials. The VAS is a visual analog scale, generally from 0 to 10, with each one marker being 1 centimeter in size. Again, if there's an MCID, it may vary depending on what you're doing, but we're usually looking for a change in score of 3 or greater. And then there's different olfactory testing. There's the upsit testing, there's sniffing sticks. Again, what is the scoring range will differ by the test, whereas the upset is a 0 to 40. And what part of that is anosmic versus hyposmic is going to vary depending on your age and gender. And again, the better the score, the better your sense of smell. And then what olfactory score you're using, that change may, the amount of change you have may vary depending on the system that you're using. So, what are we looking for when we're thinking about potentially initiating treatment? Well, first is we want to confirm we're dealing with severe uncontrolled nasal polyps. There are some things that masquerade. So, if you're not unsure, biopsy can be very helpful. We do want to check for other comorbidities such as NERD, asthma, atopic dermatitis, which is unusual to see in our nasal polyp patients. We do want to check that type 2 inflammation is highly likely, because you can see that many of these monoclonal antibodies target type 2 inflammatory cytokines or parts of that cascade. And then talk to the patient about their different treatment options, what they want, what they expect, and then whether they're interested in surgery or not. But these two things are not mutually exclusive. And look and talk to them about which potential treatment options we should select. If you are dealing with asthma, particularly severe asthma or other comorbidities, do you want to, this is really a multidisciplinary disease. You want to get your allergist, immunologist involved, you want to get your pulmonologist. Really, many eyes can be very helpful in getting the best outcome for your patient. So, in identifying patient candidates, we have our EPOS euphoria criteria. If you've had sinus surgery before, again, we're either looking for different types of type 2 inflammation, different markers for tissue eosinophilia, blood eosinophilia, or elevated total IgE. Have they had multiple courses of systemic corticosteroids? Have they lost their sense of smell? And do they have a diagnosis of comorbid asthma? So, we're usually looking for 3 of these particular criteria. Let's quickly talk about this stepwise algorithm for the management of CRS with NP. Now, this does look a little busy, but the gestalt is that the majority of patients, sinus surgery is really the first line for treatment. Many patients actually will respond well to targeted sinus surgery. And like we said, the way that we do sinus surgery has really evolved over the last 10 years. Postoperative management will definitely be saline rinses, may involve other topical nasal sprays. But if they don't respond well to this, if there is recurrence, then you can see, depending on their comorbidities, if they have AERD, you may do aspirin desensitization. They may consider a steroid implant, or you may consider a monoclonal antibody. There will be, though, very severe patients that start out. Our AERD patients tend to be more severe, and they may not wish to have surgery. They may have already had surgery. They may have had a contraindication to surgery, and we may consider going right to biologics for these patients. So let's quickly talk about a case. This is one of my patients, actually. Chris is a 12-year-old boy, and he was referred to me from Peds Pulmonary for nasal congestion. He does have moderate asthma, but he had a really thorough workup from my colleagues, ruling out cystic fibrosis and primary ciliary dyskinesia. Now, he does have some allergies, mainly in the spring and fall, with nasal congestion, runny nose, and itchy, watery eyes. But his concern was he could not breathe through his nose. He had no sense of smell. He had some facial pain and pressure, and drainage that was constantly going down the back of his throat. Incidentally, he's also seen by endocrine. He's small for size. He has started on some growth hormone replacement. He has never had any kind of surgery before, and he's on a few medicines for allergies and asthma, but he's really well compliant with him. This is his sinus CAT scan. To just quickly touch on this, these are three different coronal cuts. Anything you see that is white is bone. Anything that you see is black, that's air, and anything else is gray. That's all the other stuff in between. Skin, muscle, you'll see his eyeballs there. But the thing is, where his sinus cavities are, we should be seeing black and white, air and bone, and you'll notice that maybe there's a few bubbles, a few little black bubbles in there, but there is a lot of gray in this poor kid's nose. And that goes with what I see endoscopically. Now, if you've never seen nasal polyps, this is an endoscopic nasal view of the right nasal cavity and the left nasal cavity, and you'll notice that they look like these grapes that have had the skin peeled off of them, although there are just as many colleagues that tell me they look like cocktail onions. But you'll notice they are filling up this poor kid's nasal cavities. So, Dr. Hoyt, how would you treat Chris? Do you think he's a candidate for biologic therapy?
Yeah, that's a great question. I mean, he is a very complicated case, especially for a 12-year-old. Seems like he's had a very thorough workup to make sure that, you're not dealing with a secondary condition that's predisposing. I think here is, you mentioned the importance of multidisciplinary care. And so I think if he was in my clinic, I would right away get my ENT colleagues involved. You showed the algorithm where a lot of patients can get that one surgery and be in such a better place and maybe not need another surgery, or at the very least do a lot better. So I would start there, send to ENT, see if he's a surgical candidate. Certainly with a 12-year-old, you're going to have to get the whole family involved in that patient shared decision making, and he's going to have a voice. His parents are going to have a voice. And then, depending on how he does, I think he's a great candidate for biologic therapy in terms of the amount of inflammation that's there. So if those polyps recur, if they recur more quickly than you'd expect as an ENT surgeon, I think, there are now two biologics that are approved down to age 12. So dupilumab and tezepelumab would both be options. And, he has some other comorbidities. So the allergies, I think, would get better with both of those. Although I don't think the allergies are really relevant in terms of his chronic sinus disease and nasal polyps. His asthma may improve. He may be able to back down on some of his other therapies. So I think he makes a great candidate. But if he has the surgery and does well, then maybe he doesn't need them.
I agree. I think he is a candidate for biologic therapy. He's a candidate for surgery as well, but the awesome thing now is that he's got options. Before, he really didn't have many options. So I think having this discussion and involving, like you said, all the stakeholders can be really helpful in getting him the best result. So let's summarize all that we've talked about in our in these like really high yield 30 minutes. So chronic sinusitis with nasal polyposis is a chronic type 2 inflammatory disease. It does cause a significant burden on our patients in their quality of life. And there does tend to be, unfortunately, high recurrence rates. Now, with better surgery, that has changed. But even with the best surgery and our most compliant patients, it is a fact of life, unfortunately, that polyps do come back. Looking at the patient's comorbidity, such as asthma or AERD, can be helpful in trying to target what the best therapies are for them. And monoclonal antibodies can really help us target that treatment gap by really honing in on these key upstream inflammatory mediators. And the goal is for all the stakeholders to get together to communicate and help identify with shared decision making the best options we have for our patients' treatment. It is really critical. Thanks for that discussion, Dr. Hoyt. Now let's move on to the second part of our series, navigating treatment in type 2 inflammation-driven chronic sinusitis with nasal polyposis, practicalities and team-based approaches for selecting biologic therapies. The goals for today are that during this presentation, we will learn that incorporating biologic therapies into the treatment of patients with chronic sinusitis with nasal polyposis should be guided by the latest evidence, the inflammatory endotype of the patient, and the presence of type 2 inflammatory comorbidities. A shared decision making approach to chronic sinusitis with nasal polyposis management includes patient counseling, monitoring, and anticipating treatment results and timelines. So, to get started, let's talk about the practicalities of choosing the different biologic therapies in our patients with nasal polyps. One of the things that we are very fortunate to have is, in addition to surgery and steroids, we now have multiple treatment options. So, a number of these monoclonal antibodies are now available. On this particular slide, you'll see the first three that were approved for treatment. These are a summary of the three phase 3 trials for dupilumab, omalizumab, and mepolizumab. You'll see on the top of the slide the nasal polyp scores. These are the least squared mean changes, and the nasal congestion scores are along the bottom. Now, there are a little bit of differences between the treatment populations. So, for example, in the MEPO trial, every patient was required to have had surgery. And not just that, they had to have surgery within the last 10 years, which is really important because our surgical techniques have changed. But all of these patients were adults. They all had run ins with nasal steroids. And you'll notice that all of them are FDA approved. The two primary endpoints were the polyp score change as well as the nasal congestion score at the end of 52 weeks. The first one, dupilumab, you'll see a score of about 2 in that. With omalizumab, there was a change in the score of about 1. I know the graph is a little bit deceiving. It looks like they're the same, but it's just a different scale. And then mepolizumab, this is more a breakdown of the number of different patients that have different points improvement in their scores. Overall, the gestalt to this is sort of also what I experience with MEPO in my practice is roughly 50% of the patients improved by at least 1 point or more, but about 50% of them stayed the same or got worse. When we look at the nasal congestion score changes, though, again, there's a little bit of differences in the scoring system. The MEPO was scoring system was a visual analog scale from 0 to 10. The other two studies involved a scoring system from 0 to 3. But overall, you can see that patients' symptoms improved pretty early on in the treatment and continued in that improvement throughout the course of the trial. Now we have tezepelumab. That's the newest player on the market. Recently got approval through its phase 3 Waypoint trial. Again, similar to the other trials, the two main endpoints were change in nasal polyp score, as well as change in mean congestion score, with a polyp score to your left there and the nasal congestion score on the right. And again, this was a year study. Now, similar to the dupilumab and omalizumab studies, patients were not required to have surgery, but they could have had surgery or at least exposures to systemic corticosteroids or some contraindication that they could not have either steroids or surgery. And you'll see similar actually to the dupilumab results, there's a change of about a decrease of 2 in the nasal polyp score, as well as improvement pretty early on in the nasal congestion score that is maintained throughout the trial. Interestingly, this is something we don't see very often, which is a head-to-head trial. So this was recently reported the results of Everest, which was a phase 4 trial comparing dupilumab to omalizumab in patients that had both severe chronic sinusitis with nasal polyposis as well as severe asthma. On the top, you'll see the nasal polyp score. To the side, you'll see the change in the upset score. There's a loss of sense of smell score, which is more of a visual analog scale. And then you'll see the SNOT 22, which is the quality of life measure that goes from 0 to 110. And the takeaway from each of these trials, from each of these graphs is with this first head to head trial, now granted, this is really in patients who had severe nasal polyps as well as asthma, but strong two type inflammatory conditions, that everybody had improvement, but you'll notice that across the board, there really is statistically significant improvement in nasal polyp score, improvement in sense of smell, as well as quality of life measures that were greater in the dupilumab group compared to the omalizumab group. We have some other emerging therapies. Again, this is very, very exciting. So depemokimab, this is an ultra long lasting anti-IL-5 agent. So really only 2 injections a year. The phase 3 trials are Anchor 1 and Anchor 2, and they showed statistically significant improvement in the co-primary endpoints of nasal polyp score, as well as mean nasal obstruction on a verbal response scale versus placebo in patients with CRS with NP, and it was generally well tolerated. Stebokibart is another anti-IL-4, IL-13, a monoclonal antibody. Now, its phase 3 trial was called Crowns. And among patients with severe CRS with MP, which were treated with daily intranasal corticosteroids, it reduced polyp size and severity of nasal symptoms at 24 weeks. There were some serious AEs, but they were very rare. They tended to have higher rates of arthralgia as well as hyperuricemia that were reported in the treatment group as opposed to the placebo group, respectively. One of the things our patients will want to know is, well, which should I use, doctor? What do you think is right for me? And that can be a very complex question for our patients, and there's a lot of factors that interplay. But I feel this graph that is taking indirect comparisons from the different trials. Now, again, we have some caveats looking at this graph that there were some differences in the populations enrolled in these trials. So, for example, all of the MEPO patients in the Synapse trial had to have prior surgery, and it had to have surgery within at least 10 years. And that had to be surgery that removed tissue. So they're a little bit different. But overall, as a whole, these types of indirect comparisons for the different biologics can be a helpful guide in giving us an idea of when we talk to our patients, what potentially we may choose. So you'll notice that looking at the differences in nasal polyp scores, again, there's a little bit of difference in the populations that were enrolled, but we can see that overall dupilumab and tezepelumab were very similar in the changes in nasal polyp scores. And then it's followed by omalizumab, and then it's brought up by depemokimab, benralizumab, and mepolizumab, so the IL-5. So this kind of gives us a nice gestalt of what we might be looking for in change in nasal polyp size. But honestly, I'll say for me, even as a surgeon, size doesn't matter as much as our patient's symptoms, because even if the polyps shrink, if our patients are still miserable, then we really haven't done a whole lot of benefit. So here's another graph that kind of breaks down. Again, this is an indirect comparison, but it gives us an idea of the different changes in nasal congestion scores. Now, again, there were some differences between the different scoring systems, particularly with MEPO, which was 0 to 10, but at least this is a way where we might quickly get an idea of the potential benefits we might have in improvement in nasal congestions, where we see again the way is kind of led with tezepelumab and dupilumab, followed by omalizumab, and then the IL-5 inhibitors. Looking at change in sense of smell, whether we're looking at the overall Gestalt loss of sense of smell score, which again tends to be a rating scale either between 0 to 3 or 0 to 10, or the UPSIT, which is a scratch and sniff booklet of 40 items, and that does vary between gender and age. But again, we get an idea of improvement of sense of smell, because that's one of the things my patients will ask very commonly is, what's the chance that my sense of smell will come back? And looking at this, you can see again with this indirect comparison that tezepelumab and dupilumab tend to be more effective in improving a patient's sense of smell than the IL-5 as well as the anti-IgE inhibitors. So here's another graph, again, looking at the 4 FDA-approved options we have for our patients: dupilumab, omalizumab, mepolizumab, and tezepelumab. And I do want to call out that you'll notice that 2 of them are available for adolescents. So dupilumab and tezepelumab are for 12 and up, whereas the other 2 are for adults only. And you'll also notice that, I mean, these target type 2 inflammatory cytokines that they tend to be also approved for other type 2 inflammatory conditions. So, can biologics and surgery be used together? And do you have to have surgery? Well, most of the clinical trials, excluding the Synapse trial with Mepo, there were patients that were enrolled that did not have surgery. Now, there were patients enrolled that did have surgery. Those tend to be the majority of patients, but there were surgery naive patients. And particularly in post hoc analyses that were done looking at several of these studies, efficacy was found in both of these groups, whether or not you had surgery. So, potentially, if there is a contraindication to surgery, because let's face it, there are some patients that are too sick for surgery, there are some patients that can't stop certain medications that we would like them to stop for surgery. So, surgery isn't necessarily right for everybody, and it doesn't necessarily have to be a prerequisite. However, surgery is a great option for many patients, and a lot of us have discussed, where do biologics fit in the timing of surgery? Do we use them before surgery? Do we use them after surgery? Well, before surgery, what we're doing is looking to reduce inflammation and polyp size, potentially making surgery easier, safer, faster. And also, we've discussed that there are long term consequences to oral corticosteroid use or systemic corticosteroid use. And it is not uncommon still in practice that prior to surgery or immediately after surgery, we may give the patient a burst of steroids. Could we potentially avoid that by initiating a monoclonal antibody prior to surgery? Or do we wait till after surgery and see if the patients recur? From the DeConda study in 2017, we know that 60% of patients don't recur, and they don't recur quickly. And so maybe we need to do surgery and wait and see what happens. And if patients recur or they have tissue with eosinophilia or other markers that seem to suggest they may recur very quickly, maybe we need to initiate it more quickly after surgery. So there's a lot of debate as to like when do we start these particular targeted medications. This is one particular study that's very interesting, looking at the changing part of this dynamic. This is looking at a prospective randomized placebo-controlled double-blind trial of 30 patients where all of the patients got targeted functional endoscopic sinus surgery, but half of them got about 14 weeks of dupilumab with injections starting about a month before surgery. So they got 2 doses prior to surgery versus the placebo that occurred during those 14 weeks. And then a follow up afterwards for 1 year. This is a little busy, but I want to point out the nasal polyp scores as well as the edema scores. And overall, the gist of this is both groups did very well, whether or not they had dupilumab prior to surgery and then for a few weeks after versus just the placebo. The results were very similar, but the key things to point out with this are it did seem like surgery was actually easier and safer in the dupilumab group, and that particular group actually maintained their sense of smell, had improved smell scores at a year as compared to the placebo group. So there's some interesting things that we can look at these perioperative use of monoclonal antibodies. So this brings us to our case, Joan. So she's a patient of mine. She's a 70-year-old woman who's had a diagnosis of chronic sinusitis with nasal polyposis, asthma, and aspirin sensitivity for quite a long time. She does have a history of allergies. She's had positive allergy testing in the past, and she's been on shots for 40 years. She's had sinus surgery 3 times, each 10 years apart. The most recent surgery she had was in 2013. She's on several different medications for which she's compliant with, including budesonide sinus rinses, which she's very religious with. However, despite this, she complains of loss of sense of smell, discolored nasal drainage, and nasal obstruction. That's been going on, but getting worse for the last 2 years. And despite all this compliance with all these medications, she still had 3 rounds of prednisone 40 milligrams a day for at least 7 days, purely for her nasal polyp symptoms. She's otherwise healthy and she's never been a smoker. She did try aspirin desensitization, but she had to stop because of a GI bleed. Her IgE is not elevated. Her eosinophils are somewhat elevated at 620. Overall, though, her asthma is relatively well controlled, with her FEV1 beating 82% of predicted. Her SNOT 22 score, though, is in the severe range. Again, reminder, this is from 0 to 110, with 50 being in the severe range. Now, she hasn't had a recent sinus CT scan, and she's not interested in me getting one because she tends to associate getting a CAT scan with surgery, and she's really not necessarily interested in surgery. So she does elect to begin a monoclonal antibody therapy, and we did select dupilumab and started it at 300 milligrams every 2 weeks. And I wanted to show these nasal endoscopy pictures because this is something that doesn't always come across when we talk about our AERD patients. But as a surgeon, we'll note that not only are these inflammatory endotypes like AERD, allergic fungal sinusitis, chronic sinusitis with nasal polyposis, not otherwise specified, or central compartment atopic disease, these aren't just initials, but they can have real consequences for surgery and polyps. So you'll notice on this right nasal endoscopy where we see a picture of her nasal cavity, and we see these polyps that these ones look to me more like the cocktail onions than the peeled grapes, but you'll notice that there's some bleeding. This was really just for me gently debriding some crusting that you'll see on the left side. And even with just that gentle debridement, she started to have some bleeding. And this reminds me that patients with AERD, they're more severe patients. Their surgery can be very difficult, it can be very bloody. The polyps tend to be different. And so this is something that when we have our multidisciplinary approach, when we come together with our allergy immunology colleagues, with our pulmonary colleagues, this is one of the things we discuss about. I mean, we do like to do surgery on patients, but sometimes surgery isn't the best option for our patients. So now I'm going to turn it over to Dr. Hoyt.
Thank you. That was wonderful. So I'm going to take it over from here and talk about team-based strategies for ensuring long-term treatment success with biologics. So you were just introduced to the data behind them and kind of thinking about which one we want to start. And when we go about starting, the communication is key. So we've mentioned this before, but communication in all directions. So talking with our colleagues, right? This chronic rhinosinusitis with nasal polyps is can, because of the comorbidities, really involve a lot of specialists. So ENT, pulmonary, allergy immunology, and then, of course, keeping the primary care provider in the loop in terms of all the different moving parts. Also, among different professions, so advanced practice professionals can be very important in terms of keeping patients uh, in line in terms of their treatment, their injections, and all of that stuff in between surgeries and in between appointments and that sort of thing. And then, most importantly, I think between clinician and patient. So that patient shared decision making, we've mentioned it a few times, but really discussing those goals of care, realistic expectations. So when are these medications going to take effect if we're starting a biologic? What kind of effect can you see from the surgery, and what kind of adverse effects can you see from either therapy or intervention, so that patients know what they're getting into, they can make that educated decision, and they can have hope. If it's too early to see a benefit, then they're not going to give up right away and get frustrated. They're just going to wait. And also discussing what their goals are. So, depending on their goals, sometimes the interventions that we take as the first intervention is going to be slightly different. And so in terms of engaging patients, I just mentioned some of this, but making sure to invite the patient to participate, empowering them. At the end of the day, you're the boss, but let me give you the options, right? So presenting those options, providing information on benefits and risks. Patients really want to know this, and they don't want it to be sugar-coated. They want to know, what are my risks, and what are the percentages? So just to say that a percent of people have something is very different than knowing those numbers and being able to kind of give them context to how small or big a side effect might be. Assisting patients in evaluating options. So some patients, have done all the reading and they can kind of sift through the data and they tell you exactly what they want. And others kind of look to you for guidance. So, doc, tell me what works best and I'll do it. Or, you tell me if I should do surgery first or start a biologic. So in those patients who are asking for that assistance, you still make sure they know they're the boss, but kind of giving them the information they need. And then assisting with the implementation of, whatever decision is made. So when talking about the different interventions, we obviously mentioned medication, surgery, the fact that they're not mutually exclusive, the fact that one or the other can impact comorbidities. A lot of patients don't realize necessarily that their comorbidities are related. And so sometimes educating them on that can be very helpful. Talking about which symptoms they might expect to improve, the fact that quality of life should improve, the importance of adherence, and of course, cost is a huge issue. And so we're always navigating that with insurance coverage and copay assistance, and all of that. And so again, shared decision making, that's where it's at. Significant impact on patients' psychological well-being, their adherence as well. If they're an active member in this decision, they're going to be much more likely to adhere to their therapy. And then obviously their confidence in their provider as well, because they feel like they're part of the team. We mentioned a little bit about managing expectations. So in terms of biologics, just mentioning that initial improvement is not going to happen the next day necessarily, but in 2 to 4 weeks, you might notice some improvement, especially with regards to sense of smell and nasal congestion. Dr. Frenzies showed those charts, and you could see those numbers started improving almost right away. But that the peak symptom control can take months. So if patients start noticing some improvement, but it's not quite where they expected, make sure that they give it time. Gradual improvement's normal. And again, the response is variable from patient to patient. We talked about the different symptoms that can improve. Those patient-reported objective measures like the SNOT-22 can be very important because it helps quantify the improvement, where a patient might say, I feel a little better, but not a ton. And having those SNOT-22 scores to say like, wow, your score improved by 20, that's great. The minimal clinically important difference is 9, and so, or 8.9. And so having that objective measure can help bring context to the patient, like, look where you were struggling before, and it seems like you're struggling less in those domains. Give them hope that things could continue getting better. Biologics don't always help everybody, right? And so we want to continue reassessing in the clinic and making sure that patients, A, are tolerating, B, are able to afford the medication, and then C, of course, is it helping? And so if they're tolerating, if they're able to afford, then you probably want to give them a good 6 months on the therapy. Obviously, if there are severe side effects or anything like that, you'll switch earlier. But after the 6 months, if they're still not quite where they need to be, think about topical therapies. It could be that once they started the biologic, they stopped everything else. So sometimes we see that. And it might be that you need both, right? So getting them back on their intranasal steroid and rinses, addressing those comorbidities. So again, if they're not controlled, then the CRS may not be controlled. If all of that has checked out, then maybe it's time to switch biologics. And as Dr. Frenzies mentioned, we've got a lot of options, especially for our adult patients. So not being afraid to switch. Sometimes patients are afraid to switch, but then just reminding them that this is not a final decision. If the first one ended up working better than the second one, we just switch back. And so sometimes that gives them the confidence to say, okay, I'll try something new, and maybe it'll be better. And if not, I have that option to go back. And then again, that multidisciplinary care, so surgery, may be needed in some patients who kind of deferred that extra surgery in order to try the biologic. But if it's not quite cutting it, then maybe it's time to go back to the OR. And then we talked about setting these realistic goals, about kind of where does the biologic fit in, what does it have the power to do, but then also maybe what sometimes it doesn't do. So, in terms of defining response to biologic therapy, the 5 criteria we think about are going to be the nasal polyp size. So, we need endoscopy for that. Systemic oral corticosteroids. So, again, that's a main goal of ours to reduce the need, improving quality of life, improving sense of smell, and then reducing the impact of comorbidities. So, if 4 or 5 of these improve, then we've got a good to excellent response. If 1 to 3 improve, it's a poor to moderate response. And obviously, if none of them improve, then we've got no response. And so after 6 months, we're going to evaluate the treatment. If we talked about kind of reevaluating, and if we kind of can make some tweaks, then we can leave them on and evaluate treatment again after a year. But if at any point it seems like we've kind of done everything we can with the biologic and in conjunction with the topical therapy, then it might be time to discontinue that therapy and kind of go back to the drawing board and figure out, is it time to switch to a different biologic, or time to maybe think about surgery. For our partial responders and our complete non-responders, again, the evaluation is going to be about some improvement or no improvement, and the strategy is going to be, again, either continuing the therapy and monitoring, but considering a dose taper if they're stable. But then, of course, if there's no response at all, switching the biologic or thinking about surgery. And so, kind of on that note of possibly extending the dose or tapering therapy, this is a study surveying the ARD registry at Brigham Women's Hospital. So again, these are our most severe CRS patients in general, and the dosing interval for these patients. So patients would try on their own to kind of space out from the typical every 2-week dosing of dupilumab to every 3 weeks, every 4 weeks, or even some patients went every 4 to 8 weeks. And you can see in the pie chart, many patients ended up going back to the every 2 weeks, about 25%, and then 6% actually ended up needing it more often than every 2 weeks. But the vast majority of patients were actually able to wean to every 3 to 8 weeks. And so that's just important. I mean, these patients love their biologics once they're working. They never want you to take it away. But after a certain while, they start kind of talking about, maybe we could space it out a little. And I'm all for that as long as control is maintained. So about 1/3 of patients in this study did try it and were able to, stay on a dose that was greater than every 2 weeks. And most common successful dosing frequency was every 3 weeks. So let me show you results from another study here looking at tapering dupilumab. So you can see in the very light color is going to be every 2-week dosing. And then as it gets darker, patients are spacing it out further and further. So the light teal is every 4 weeks, and then the darker, the green is every 6 weeks. The forest green is every 8 weeks, and then the really dark green is every 12 weeks. So imagine a patient is able to actually use it every 3 months. And you can see more and more patients over the course of 96 weeks were able to space out their dose. And there was still a very small percentage at the end that had to stay on that every 2 weeks, but most patients were able to wean. And despite weaning the dose, you can see in the other 2 tables on the right that their control actually was better. So patients who were uncontrolled is kind of that darkest purple, and that amount decreased almost immediately at the 4-week mark, and then even further at the 12-week mark, and then really maintained quite low the rest of the time, despite the fact that many of them were weaning their therapy. Similarly, with the Euphoria 2023 response evaluation, right away there was a decrease, and then again it was maintained despite the dosing being tapered. Similarly, the sniffing stick, so there the score went up, which is good, and then was maintained despite the dosing tapering. SNOT-22 score, same thing, score went down, which is good, was maintained. And then the nasal polyp score as well went down almost immediately and was maintained despite tapering of therapy. Another question is about, is there any sort of disease modification where maybe we could stop the medication altogether and then continue with clinical benefit? And so this is a study looking at Synapse, which was the pivotal mepolizumab trial, but kind of a post hoc analysis thinking about the patients in the follow-up period. Are they also continuing to have improvement? And so even though their blood eosinophils returned to baseline by the 76-week mark, and they had stopped the mepolizumab at 52 weeks, most of them continued to have an improvement in terms of symptoms. So important to think about, and we don't know obviously long-term beyond that 76 weeks, but just an important thing to kind of keep in mind. So back to our patient, we have Joan who comes back. Now she's been on dupilumab for 9 months, and she notes a great improvement in her nasal congestion and restoration of sense of smell. Her asthma continues to be well controlled, but now she even needs her rescue inhaler even less. Her SNOT-22 score, if you remember, was 55 in that poorly controlled group, and now she's 18. So huge difference in her SNOT-22 score. And so together, Joan and we decide to taper her therapy. So every 3 weeks and see how she does. Of course, we mentioned that if things get worse at any time, just go back to the every 2 weeks, give us a call, but let's see how every 3 weeks go. And so 6 months later, she comes back and everything is just as good. So despite weaning, nasal congestion, sense of smell have remained the same, and they haven't worsened with that tapered dose. So a real success story. And then again, being able to taper is even better. And potentially the next step would be to taper even further. And then looking at her nasal endoscopy, I'm going to turn it over to Dr. Franzese, who's the expert. But even a non-expert like myself can see that there's a huge difference there.
Yeah, and so she was someone we would call a super responder. Certainly, this isn't your typical or average response, but one of the things to point out is, so we're looking at her nasal cavity. We have the left side, we have the right side. And one of the things surgeons will debate too is, have they had good, adequate surgery? And her anatomy has been very surgically altered. And you'll notice there's some very large holes there. That is what we call large hole surgery. So you'll see that, particularly on the left side, you can even see where part of her septum has been drilled away, where you can actually look directly into her frontal sinus. That's called a lothrop. She's also had very large megaantrostomies, and you can actually see directly into her sphenoid sinus all the way on that left side as well as the right side. But she's had such a great response. You can see very few polyps. She was very happy, but she had good sinus surgery, and despite the fact that she had good sinus surgery, she still had polyps. So it was awesome that we could offer her this option.
Especially after 3 surgeries, I'm sure she did not want to go back for a fourth. Thank you. So with that, I'll give you the summary and key takeaways. So multiple biologics are available. We're thrilled about this. It gives our patients so many more options, and others are in development. The optimal sequence of surgery and biologics, that still remains undefined, but biologics can be effective in patients with or without a prior surgery. Shared decision-making is critical. Long-term strategies may include tapering dosing intervals, as we mentioned in a couple of studies looking at that. And then multidisciplinary collaboration supports optimal patient outcomes and continuity of care. So with that, thank you for joining us. And thank you to Dr. Franzese for your excellent insight into the discussion. We hope you found this activity to be useful in your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/MNA860.